Um, Before I go into a whole lot of information about the TURP procedure, I took the time to discuss with the urologist what procedures were being done for BPH these days, because recently I know that have been different surgeries being performed. I had friends whose parents or fathers had different surgeries done than the TURP, and so I wanted to kind of get an overview of, because I know our book is slightly dated, like as any textbook is. So I wanted to kind of get a little bit better feeling on where we were with TURPs and how often they were being performed. At present, they are still the gold standard for surgical treatment of BPH. But they are starting to use more other procedures, such as the Halo Leap, which is where they're lasering off part of the prostate. And then they're also performing a robotic assisted simple prostatectomy, or the RAS procedure. Now, keeping in mind, if they take out the entire prostate, there is different problems that the patient may have, but will no longer run the risk with prostate cancer. And so we'll talk about that just slightly more in the next section. So we're going to stay with the BPH patients for right now. But the gold standard is still the TURP. I will speak of briefly, but just keep in mind that most of the time they are trying less invasive procedures, such as endoscopic procedures, such as the HOLEP, which is where they laser off part of the prostate, instead of the TURP. Again, patients who require surgical management are ones who are having acute renal retention. They're having chronic bladder tract infections or urinary tract infections. They're having hematuria, and they may even have hydronephrosis. So these are the patients who usually will have the TURP procedure. The disadvantage of a TURP procedure is that only a small piece of the gland is removed, and that's the same with the laser procedures. Because only a small piece of the gland is removed, the remaining prostate may continue to grow and again obstruct urine flow, requiring additional TURPs. Now, keeping that in mind, people who have the minimally invasive procedures, such as the laser procedure or the RAS procedure, the robotic assisted, usually do not have or require continuous bladder irrigation after surgery. And they are usually discharged within 24 hours. These patients also, just like the patients with the TURP, most of these patients are discharged home with a catheter in place. When you're taking care of patients postoperatively who have had a TURP, or any patient who's had who needs continuous bladder irrigation, it's important to know how that operates. So what you do is, if you look at figure 72-3 on page 1480, or if you can look at the little picture here on the video screen, you see that the Foley itself, it's very hard to see, I think, in this picture here. It is a three-way Foley catheter. The three-way Foley catheter, you have one port that is going to the irrigation solution, okay? You have one port that is for the balloon, and this isn't any little balloon. This sucker is usually between 30 and 40 cc's of sterile water in this balloon. It is huge. So they usually have it marked on how much fluid they have in the balloon holding it in place. And then the last port, let me see if I can get it to wiggle here. The last port here is where you're going to have the output. Now, remember, that output is both coming from the irrigation and from the bladder itself. So it's very important to keep very, very accurate INOs and make sure you know how much fluid is being instilled into the bladder, so that you know how much in the catheter drainage bag is urine and how much is irrigation fluid. Again, intake and output is extremely important with these patients. It has to be done very accurately. You have to make sure that you keep up with the amount of irrigation fluid being placed into the bladder, and so that you can tell how much urine output these patients are having. If you look at chart 72-1, you'll see it talks about the care of the patient after a TURP procedure. Big things are to make sure of is that they know to be very careful not to pull on the Foley catheter. You need to make sure that these patients are being assessed every 2 to 4 hours. A lot of times they require pain control. You want to keep the flow of the irrigation fluid enough to keep the urine or to keep the irrigation flow good and without clots. A lot of times the urologist will say continue irrigation solution to keep urine at a light pink, or they'll give you something to that phrase. Or when he's in the room, he'll go, this is the color I want it, I don't want it any darker. Or they'll say make sure the urine stays transparent, something to that effect. There's not really like a number of cc's per hour. It's usually to keep the from becoming too viscous, or to, of course, you don't want blood clots to form. But usually the surgeon will give you some type of like that they wanted the color of a light cherry. They want it to be able to be see-through. They'll give you something in their orders that will tell you where you want the irrigation fluid to be at. So it's not like a milliliters per hour. It's keeping up with the keeping the urine the color that the provider wants it to be. These gentlemen usually have a lot of trouble with pain, but it's usually not pain that a narcotic is required for, or even that a narcotic will work for. A lot of times what these patients require is an antispasmodic medication, because a lot of times their pain is being caused from bladder spasms. If you think about it, the bladder now has all these clots in it. It has this huge Foley. It has all this bladder irrigation going through it, so it's getting irritated. So with that irrigation and everything going through it, you're going to have trouble with bladder spasms, and bladder spasms can be very painful. They can actually cause urine to come out from the sides of the catheter, and they're prescribed antispasmodics to control that. With that being said, bladder spasms can also cause patients whose bleeding had been controlled, and their amount of clots and the darkness of their urine had decreased, even with decreasing the amount of irrigation fluid, had been controlled. And then what happens, unfortunately, is with these bladder spasms, they can have a rebleed, and it can become a medical emergency. So keep in mind that usually patients who are going to have hemorrhage issues are in the first 24 hours, but because of the bladder spasms, these patients can have a risk of hemorrhage later. So it's important to make sure that we're giving medication for bladder spasms, the antispasmodics, with these patients. These gentlemen are discharged home with a catheter. Again, these are the gentlemen who have the TURP procedure. Also, even though I'm going to talk about prostate cancer more in just a minute, patients who have radical prostatectomies or the minimally invasive RAS procedure also are sent home with catheters. Making sure that your patient has appropriate patient education for going home with a Foley catheter is extremely important. This care is actually discussed in the next section. It's chart 72-3, patient and family education, preparing for self-care, urinary catheter care at home. But with Foley care at home or catheter care at home, it's extremely important that you teach your patients how to care for them. Make sure they're given enough supplies to go home with. Make sure that if your patient has not been circumcised, that they push the foreskin back to clean, but then they place it back over. Remember, never leave a foreskin on a gentleman retracted back, because that can cause serious issues and can become an emergency very quickly. So remember, if you have an uncircumcised male, make sure you pull the foreskin back over the catheter, and don't leave that retracted back. Okay? But these care instructions are very thorough on chart 72-3 on page 1486, and it's very important. Big things to remember is to make sure they keep it clean, make sure they're doing proper catheter care at home, make sure whoever's helping them is washing their hands at home, make sure that they know that they can take a shower, but they cannot take a tub bath. with the catheter in place. And I'll repeat one last time. If they have not been circumcised, make sure they clean. They bring the foreskin back to clean, but then they do make sure that they replace that. And that they do not leave it back. That's more so important in the hospital when doing Foley care on a gentleman who has not been circumcised. Make sure you retract the foreskin back to clean out the smegma, but do put it back over the Foley catheter. I'll get off my soapbox. If anybody ever wants to hear why I have a soapbox on that, please see me personally. But always remember, patients with foreskin, make sure you retract back. There we go. We're going to talk just briefly about prostate cancer. Prostate cancer is caused by a number of factors. Advanced age is the leading risk factor. Also a risk factor, it can be familial. A first-degree relative, whether it's a brother or father with the disease, increases your risk for the disease. Other factors include their diet, whether it's high in animal fat, including red meat or refined carbohydrates, can also be risk factors for prostate cancer. Prostate cancer is the second most common type of cancer in men throughout the world, but if found early enough, it can have a 100% cure rate. In men older than 65, they have a greater risk of the disease. Having routine PSA blood tests is one way that prostate cancer is caught early when it is still encapsulated within the prostate. Operative procedures have changed throughout the years. The most common procedure now is a laparoscopic radical prostatectomy. Is the most common procedure for prostate cancer. It is no longer the open radical prostatectomy. With the less radical approach and the laser procedure, it has decreased their length of stay to only 1 to 2 days instead of almost a week. There's minimal bleeding, less postoperative discomfort, decreased time with the amount that they're going to have the urinary catheter in place. This is for the patients who have the robotic-assisted laser procedures. They have fewer complications. They have faster recovery time and return to usual activities. And its nerve-sparing advantages. It a lot of times does not have the erectile dysfunctions that the radical prostatectomy does. Again, the newer procedures such as the laparoscopic radical prostatectomy and the ultrasound-guided procedures are minimally invasive. It has decreased length of stay, minimal bleeding. These patients have less postoperative discomfort. There is less nerve damage, so they have less trouble with erectile dysfunction, and a lot of times they have less trouble with incontinence as well. And so this is important to keep in mind. When taking care of a patient with an open radical, which is not common anymore, so I'm not really going to take a whole lot of time talking about it. It's again just going over that care of the Foley catheter and that they can have trouble with incontinence issues and intimacy issues. And that's where I'm going to stop our conversation on prostate cancer for now. If you have any further questions, don't hesitate to ask.